Everybody gather near. The doctor's in the house, so lend him your ear. The things he can say might even make your day. He might even help your pain go away. The doctor is in the house. The doctor is in the house. Let the doctor know what's bothering you. I'm sure he can tell you just what to do. The doctor is in the house. Doctor is in the house. Let the doctor know what's bothering you. The doctor is in the house. If you have a pain, call a doctor. If you have a sprain, call a doctor. Let the doctor know what you're going through. Let him tell you what's good for you, because the doctor is in the house. The doctor is in the house. Call the doctor. Call the doctor. Call the doctor. Call the doctor. Tell me what's happening there.
Hello, everyone. This is Dr. Ron, host of Dr. Ron Unfiltered, Uncensored. This program contains general medical information. The medical information heard on this program is not advice and should not be treated as such. You are encouraged to confirm any information obtained from this program with other sources and review all information regarding any medical condition or treatment with your physician. And ladies and gentlemen, we are really pleased today to present another encore presentation with Dr. Russell Jaffe, a world-renowned practitioner. He is joined for this episode with Dr. Jerry and myself to talk about predictive biomarkers. And when compared to healthy goal values, results of these 8 independent primary predictive tests are effective forecasters of individual health risk or resilience. You can function years or even decades younger than your birth age by just bringing or keeping each of these biomarkers at their predictive healthy goal values. Dr. Jaffe has a long history with this technology, and the message he brings you can save your life rather than put it into someone else's life, someone else's hands. You will hear about genetics and epigenetics and how they control your health and how these predictive biomarkers can guide your therapy. And they will include insulin, high-sensitivity C-reactive protein, homocysteine, lymphocyte immune tolerance, your pH, your vitamin D levels, your omega-3 and 6 ratio, oxidative damage, and how that can be measured. So I hope you enjoy this. Dr. Jaffe is just well-renowned, and he is just a tremendous person, and he simplifies health monitoring and presents us today with these 8 predictive biomarkers.
Chairman of PERC, Integrative Health.
So
it's
PERQUE.com.
This is a company that offers the world scientifically proven integrative health solutions to speed the transition from sick care to healthful caring. Dr. Jaffe has more than 40 years of experience contributing to molecular biology and clinical diagnostics. His focus is on functional predictive tests and procedures designed to improve the precision of both diagnosis and treatment outcomes, and he has authored nearly 100 articles on this subject. He received his bachelor's degree, his medical doctorate degree, and his PhD from Boston University School of Medicine. Completed residency training in clinical chemistry at the National Institute of Health, NIH, and remained on the permanent senior staff before pursuing other interests, including starting the Health Studies Collegium think tank. Dr. Jaffe is board certified in clinical pathology and in chemical pathology. He is the recipient of the Merck Sharp Endowment Excellence in Research Award, the J.D. Lane Award, and the USPHS Meritorious Service Award. Dr. Jaffe was honored as an International Scientist of 2003 by the IBC, Oxford, England, UK, for his lifetime contributions to clinical medicine, biochemistry, immunology, methodology, and integrative health policy. He is widely published and sought after to explain complex subjects to any audience. Dr. Jaffe is also the founder and chairman of ELISA/ACT Biotechnologies and Magic Biotherapeutics. Ladies and gentlemen, this is a real rock star. I've been reading his work since 2014, and although this sounded complicated, he can break down what we just said into terms that you can understand. And basically, we're going to talk about some blood tests today, blood tests that are called predictive biomarkers. And they're different than the blood tests that you get when you go to your doctor. As I'm finding out here in Florida, a good doctor is defined as a doctor who orders lots of tests, x-rays, CAT scans, and MRIs, and does very little examining. What I'm finding here in Florida is when all the tests are normal, they finally examine the patient. Well, we'll talk about that. Dr. Jaffe, good afternoon, sir, and Dr. Jerry Smith will join us shortly.
Dr. Ron, a pleasure to be with you. And I certainly
Thank
appreciate your reading that introduction just the way my mom wrote it.
Well, you have a terrific person in Justin, I got to tell you. If I was in practice, I would try and steal that person.
No, you can't poach him. Sorry. Thank you. I'll give him the feedback. We have a great team, and we're very privileged to have it.
That is great. Dr. Jerry, is that you on the phone?
Yeah, it's me.
Oh, good.
Okay,
Hi, Dr. Jerry. How are you?
Terrific. Yeah, I just was telling Ron earlier today, I've been using your products for many, many years. In fact, you're right in my backyard. I think you're in the Princeton area, right?
Well, I was at the Princeton Bio Center. I'm really based in Vienna, Ashburn, and Sterling, Virginia now.
Oh, okay, now. But, yeah, I heard you lecture, I think, one time over in the Princeton area. I'm in the Newtown, Langhorne area.
Oh, that's right. Yes, we Nassau Club and various other venues in that neighborhood.
Yeah. So your products are great, by the way.
Thank you. Appreciate the feedback.
Yeah.
Well, Dr. Jerry, I already introduced our guest, and I thought as I spoke with his personnel that maybe we just have a conversation this time and maybe get more specific as time goes on. And maybe, Dr. Jaffe, just explain what conventional blood testing. When I go crazy when all my friends say, I went to this doctor, he ordered 10 pages of tests, he's really good. Explain how they arrive at the normals for these chem profiles.
Well, with regard to the chem profiles, the CBC complete blood count, the Chem 20 studies, they are routine. They've been routine since I was a young physician. They are referenced to a range, and usually the doctors say that the number or the value of the test is within the range or outside the range, as if there is some individual meaning to comparing that individual with that statistically determined, mathematically determined range. In the 1970s, that was the best we could do. Today, we deserve better. There are many tests, hundreds of thousands of them actually. There are many biomarkers, thousands of them, but there are only 8 predictive biomarkers that cover all of what we call epigenetics or lifestyle. All of the things you can do something about are covered in those 8 tests. They have been validated on every population, every socioeconomic group, every geography, and they even give you, if you want, a prediction of 10-year survival, which, while that's interesting, what's more important is that within a few months, for most people who are not at their goal value, they're not at the best outcome value for that biomarker, that predicted biomarker test. Because if they were at their best outcome, goal value, they would have a 99% chance of living 10 plus years. And if they're at the usual level, say most people go to their doctor. They're within the usual range. They're within the so-called normal range, as if that has something to do with normal. That has to do with statistics. And I'm not going to get into the mathematics of it, but the bottom line is we should all be doing the 8 predictive biomarkers and looking at whether we're at our best outcome goal value or not, and then taking lifestyle steps for 3 to 6 months to see how close you can come back to that best outcome goal value. And in individualized cases, we go through another 6-month cycle where we look for biochemical individuality. So it's not once and done, but it is a matter of adding life to years, years to life, and in most cases, reversing the loss of decades of quality life so that you feel and function better, you get better restorative sleep, your moods are more stable, you're able to concentrate and remember, etc.
Well,
so
Dr.
we're
Jaffe,
talking about being proactive about your health, and if you would, just explain to our audience again about the epigenetics.
Right, so let's start with
genetics.
epigenetics. Right, let's start with epigenetics, right, because it's not genetics. So genetics is the DNA, although it turns out your DNA is not a blueprint. It's constantly changing under the influence of your environment. Epigenetics is a word that because epigenetics, we used to call it lifestyle medicine, but you get paid better if you use Greek and Latin words like epigenetics. Epigenetics covers 92%. This is an NIH figure that's been reconfirmed for decades. 92% of the quality of your life, of your health status, even the duration of your life, is determined by these predictive biomarker tests. And the usual chem profiles, which were fine in the 70s when Galen and Gambino, colleagues of mine and friends of mine who wrote a book called Beyond Normality, and that made all these profiles possible and now widely used. And while they may have had utility in the 20th century, in the 21st century, we need the predictive biomarker tests, and we need to know the goal values, the best outcome values, and we need to make changes in what people eat, drink, think, and do to bring them to their best outcome values.
Yeah, Dr. Jaffe, is this a type of test if they go to their family physician, he's going to understand it or have access to these, or where would someone go to get them?
Well, you can get them, and we can go over the 8 tests so people can take note if they want. You can get them from almost any physician. However, most physicians, as I've indicated, get a report from the lab, and I understand that in certain states of the union, the more pages to the report, the better the doctor, whatever that means. And what I'm saying is do the 8 that have meaning and take action rather than do the hundreds or thousands of tests that you just get a harumph because there's nothing you can do about them. They reflect that your kidney is a kidney and your liver is a liver and your bone marrow is a bone marrow, and that's a good thing because you want all of those things. But when we talk about epigenetics, now we're talking about things that you can influence for better or for worser. And if your habits of daily living are shortening your life and increasing your suffering, we can identify where that's occurring and what to do about it. And that's where it's different than the usual, well, you're inside the normal range or not.
Okay, so Dr. Jaffe, let's, if you would please, let's go through the 8 tests that you have listed so that people can live longer, not just and healthier, not just longer, but longer and healthier. Maybe we can go through that list.
Oh, sure. Let's start with one that's familiar to many people. It's hemoglobin A1C. Today, as a diabetologist or as someone who's interested in sugar balance in people, I no longer pay attention to fasting blood sugar or blood sugar insulin ratios or things like that, but I pay a lot of attention to hemoglobin A1C. Paul Gallup in the 1960s found that when the body has a need for more energy in the battery of the cell, in the mitochondrial battery of the cell, the body raises the blood sugar in order to put more sugar fuel into the cell to rehabilitate the mitochondria. So your hemoglobin A1C should be less than 5%. If it's 6%, you're an average American and pre-diabetic. If it's 6.5% or more, as it often is, you are diabetic, and the quality of your life is impaired in every way. Cardiovascular risk goes up, cancer risk goes up, digestive problems go up. A lot of things actually have to do with impaired sugar metabolism that the hemoglobin A1C test tells you whether you do or don't have an issue with that. So that's number one. Now, we can talk a little bit more about that, or I can go on through the list of the 8, and then we can, put it together in any way.
Well, let's just stay with that for a second. I mean,
Okay.
most diabetics know about this test, but most non-diabetic, so-called healthy people, I don't see physicians ordering this on any kind of regular basis in a person that does not have a high blood sugar.
Dr. Ron, I completely agree with you that most doctors are stuck in the 19th or 20th century. They're doing tests that may have been suited to the 19th and 20th century. They're not knowledgeable about the contemporary science literature that has shown for the last 25 years that hemoglobin A1C is a meaningful test of average blood sugar and much more clinically useful than fasting sugar, 2-hour postprandial sugar, GTT, insulin glucose ratios, HOMA. These are things that I did as a research procedure. We have the most successful outcome study in type 1 diabetes and type 2 diabetes, and we're happy to share that with clinical colleagues because one of the 8 biomarkers relates to that aspect.
Now, I just want to make sure our listeners understand that this is a test that should be asked for even if you're not a diabetic.
Everyone should know their hemoglobin A1C, and everyone should know that the healthy people have less than 5% sugar stuck on their hemoglobin, so their hemoglobin A1C is less than 5%.
Dr. Jerry?
Do you have like a nutritional protocol if someone A1C is out of balance that you could recommend?
Well, yes, and what we really recommend is to put the 8 tests together as a suite or as a unit, and then let us guide you depending on your particularities. So we ask people to fill out a 15-minute questionnaire. It's called an HAQ, a health appraisal questionnaire. There are so many possible things that can influence adversely hemoglobin A1C that if I just gave you the whole laundry list, they wouldn't know what to do because all people don't need all the things that are essential for a healthy hemoglobin A1C. What we have figured out over the last 40 years is how to parse that question. So if you'll give us the benefit of the specimen, blood or urine, and the HAQ, the health appraisal questionnaire, then we can come back and be very specific. Is it chromium and vanadium? Is it a lack of an herb that, like banaba, that enhances the insulin receptor? Is it related to pituitary endocrine influences on cellular metabolism? Is it related to magnesium deficiency or choline or citrate deficiency? I could continue because there are many, many things that can cause your hemoglobin A1C to go up, aside from a hyperactive fork or eating too much sugar.
Okay.
Right. So basically, it's a global approach to reestablishing health, as opposed to just replacing a spark plug.
Exactly right. We are not machines that break down. We are self-renewing, and when we have all the good things and lack the bad things, we renew ourselves. In fact, no part of you, Dr. Jerry, or me, is more than 10 years old, and that's our bones. Our blood vessels and large joints are 7 years old, and most of us is new in the last few months. So this notion that I'm wearing down or wearing out or I'm aging, that's an illusion. What it means is you're lacking the essential things that help you repair, and you have too much distress or toxic exposure from the environment that is impairing your basic chemistry.
That is really a great point, and I think our listeners will probably have to listen to that again. Is that most of our cells regenerate every 7 years. That's just a generality that I have talked about for years now, and that we're not stuck, ladies and gentlemen. We are not stuck where we are. We can do something about it.
That's the good news.
So, Dr. Jaffe, that's hemoglobin A1C. what is your
right,
next
so that's the first
test?
one, hemoglobin A1C, and the best outcome value that you should have is less than 5%. The second one has to do with repair. It's actually the measure of repair deficit. This is known as inflammation, and inflammation is connected to almost everything that makes us ill. What we did was look at the molecular mechanism of inflammation, and we found it to be repair deficit, and we correct it by correcting the repair deficit, not by suppressing and fighting with the consequences of the inflammation. In addition, we have a test, not that we developed. This was a test that Paul Ridker refined with the help of Rafai up at Harvard. It's called HSCRP, and that's an abbreviation or an acronym for high sensitivity C-reactive protein. So there was an A reactive protein, a B, and a C, and a D reactive protein. And the C reactive protein is an exquisitely sensitive measure of your ability to repair, also known as inflammation. And the goal value was less than 0.5. And most people are above that, indicating that they have chronic repair deficit and inflammation.
You know, it's interesting, you know, from a dental perspective, because that's my primary background, there's a lot of infections in the mouth and, you know, toxic metals and, you know, dissimilar dental materials and toxic materials that can create this hypothyroid and also chronic systemic inflammation that most physicians don't even, you know, factor into the healing equation.
You're quite right. The mouth is the window on the body. Healthy gingiva, healthy gums are so rare that if you have them, send me a picture. The reason that saliva is not very useful on many tests is because you don't just get parotid or submandibular saliva. You get serosanguinous fluid from the gingivitis, from the inflammation and repair deficit in the mouth, which is reflective of the systemic repair deficit that the individual sustains. And you're quite right. If you just took everyone who comes to a dentist and you had them do a C cleanse, you had them taking enough polyphenolics, had them taking enough magnesium to balance their calcium, but in forms that can be taken up and chaperoned for delivery, other essential nutritives, and you improved the ability of the repair cells, because remember, it's the immune defense and repair system. So our immune system does defense first. When the HSCRP is above 0.5, then the immune system is on alert doing too much defense work and not able to complete the job. It's not able to complete the repair, because if the repair was completed, the HSCRP would be less than 0.5.
Okay, that's all right. So now we have two tests, and did you mention that reactive protein could be related to an underactive thyroid, or was that Dr. Jerry?
Well, Dr. Jerry raised it, and he's quite right. When you put oxidative molecules, toxic metals, foreign substances that people have delayed allergies to, etc., when you put those in the mouth, you're setting the stage to deplete the body of the essential antioxidants from ascorbate to polyphenolics, etc. And the consequence is systemic repair deficit, inflammation, and then the HSCRP is above 0.5. And what you want to do then is stop the assault, reduce the toxins to the extent that you can, chaperone their removal from the body in safer, biologically compatible ways, and then restore the essential nutrients that have been eaten up by the oxidative stressors like toxic metals, hormone disruptors, solvent residues, mold products, etc.
Well, you know, Dr. Jaffe, you know, one of the biggest problems, you know, I think there's like 27 million root canals that are done yearly, and
yes,
as you well know, it puts out a plethora of toxins and bacteria and chronic inflammation, and unfortunately, you know, high percentage of dentists think that this is the gold standard, and unfortunately,
They're taught that that's the gold standard. They're taught at Forsyth Institute. They're taught at VU dental schools. Henry Baxter, the dean of the dental school at VU, was a big advocate for that. And he and I had debates. And he came around to say that there was a legitimate concern that people should avoid root canals if at all possible, and they should be explained the consequences of root canals if they're going to have them.
Well, that's an enlightening response.
From a dean of a dental school. I thought
absolutely.
that was pretty enlightening.
Okay, so Dr.
Now, if you
Jaffe,
want, we
maybe
can go on to number 3.
Let's move to number 3.
Yeah, number 3. This is it's called homocysteine, HOMOCYSTEIN, homocysteine. This has to do with methylation. This has to do with regulation of your genetic code and how it gets translated, transcribed, and delivered to you in the form of new proteins and new structure and repair, etc. So it's kind of important. In the 1960s, Kilman-McCulley showed that if your homocysteine was above 6, that you're at risk of accelerated cardiovascular disease, atherosclerosis, stroke, kidney disease, etc. Others have now found it to be an all-cause morbidity and mortality indicator. So if your homocysteine is up, in addition to cardiovascular risks, your risk of cancer and of other chronic illnesses and of pain syndromes goes up dramatically. So we know that the healthy people have a homocysteine of less than 6, and that's what your homocysteine level should be. What that means is that your methionine is higher and the homocysteine is lower, indicating the ability to methylate and demethylate the DNA, the RNA, the genetic material efficiently. And it's the third of the 8 biomarker tests.
Okay. Well, we can come back to that one.
Most people are deficient in B vitamins, which we all should know that the B9, 6, and 12 help to reduce the homocysteine level. But today it's all synthetic.
Well, no, you should have nature's form of the B complex. You always have balanced Bs, since the 1950s. And, of course, you have enough to keep your urine sunshine yellow. Now, that means you're hydrated and yellow like the sun, because if it's muddy brown or dark yellow, you need to drink more water because it's precipitated. It's concentrated, too concentrated. So you want a healthy B complex that's reflected in a sunshine yellow urine. And for most people, that means a dramatic increase in the amount of B complex they take.
Okay, so and we will come back to the overall treatment if we have time or at another visit with you. But let's get on to number 4.
Number 4 has to do with your immune defense and repair system. It's the LRA by ELISA Act. It measures all of the harmful but not the helpful antibodies, and it picks up immune complexes, and it picks up T cells. So we have the white blood cells that produce antibodies, and then we have the white blood cells that directly interact with our immune defense and repair system, and they're called T cells. That's from thymus, for those of you who are technical. The thymus is a gland inside your chest that has to do with maturing your immune defense and repair system cells. And so T cells respond without antibody activation. Only harmful antibodies are a problem, and most antibodies are neutralizing, beneficial, and helpful. So our lab pioneered the ex vivo LRA by ELISA Act. LRA stands for lymphocyte response assay. So you actually have white cells responding in our laboratory just as they do in the body. So it's an ex vivo as opposed to in vitro. In vitro means in the test tube. Ex vivo means just as it happens in the body. It's a test that emulates the body in the laboratory, and we can do now hundreds of foods, chemicals, medicines, and toxins on 1 ounce of blood, as long as the blood gets to us overnight. And there's a simple preparation so you don't have pre-activated cells. And now a new generation of functional immune defense and repair tests is available that was not available before. And now we don't have to fight with the signs of impaired immune system. We want to substitute for the reactive foods, chemicals, and medicines. We want to enhance the tolerance in the immune defense and repair system. And then we want to come back after 3 to 6 months of substitution and see if you have restored digestive competence and lost reactions, or if your digestion is still undernourished, if you will, if it's still impaired to some extent, and it is for many people, even after 6 months of diligence, because it took years to decades to get into your office. Even in that situation, we can come back after 6 months, repeat the test, see if you have lost some reactions and maybe acquired some others because your digestion isn't perfect on the second day when you start this program. So very often people come back after 6 months and they repeat the program, sometimes even a third time, and in many cases going from significantly disabled to significantly enabled just in a few cycles.
I just want to make sure our listeners understand that's the LRA test, lymphocyte response assay.
Yes, LRA by ELISA Act, LRA. Yes, that would be less familiar to most doctors. The first 3 tests, if a doctor hasn't heard of the first 3 tests, go to another doctor. They might not have heard about the goal value. They might not understand the predictive biomarker use of the test. But those first 3 tests, everybody, if you're a licensed professional, you should have heard of them, at least heard of them. You may not use them, but start using them. Now, the fourth.
Well, that's why I want to make sure they hear that again, because that's one that no one talks about. So
yes, LRA, lymphocyte response assay, LRA by ELISA Act. You can go to our website, elisaACT.com, and get as much information as you want, either as a consumer or as a professional.
So if your physician doesn't know about the first 3 biomarkers and has plants that are dying in his waiting room, leave immediately.
Well, I do agree with you, Dr. Ron. Do you know that when I go into this, doesn't happen often, but when I go into a doctor's office, if they have plastic plants or dead plants or nobody's paying attention to the plants, I just walk out.
Exactly.
I'm sorry, I won't.
That's what's called reception. That's a reception room biomarker.
That's a reception room response. At least I'm being candid with you. I want someone who cares about every aspect of their environment, and I want to feel a healing presence, including, healthy plants or a little water course, or there are many ways of doing it, but somebody should pay attention.
I love it. Dr. Jaffe, let's go on to number 4, maybe something that physicians should know about also.
Number 4 with the LRA. Yeah, number 4 with the LRA by ELISA Act. I'm going to reinforce that one because it may be, new to many people. LRA by ELISA Act is number 4. Number 5 is one that should be familiar, may or may not be. It's properly measured vitamin D. Vitamin D is a neurohormone. We call it a vitamin, but it's really a neurohormone. And the healthy range is 50 to 80. Some people will tell you it's 40 to 90. Other people will tell you it's 60 to 100. My range, my proposed optimum range is 50 to 80. Most Americans are below 20. At a consensus conference that I recently attended from the National Cancer Institute of the National Institutes of Health, they said that if you have less than 20 for the 25-hydroxy-D, so you don't want to measure the 125. You don't want to measure the 1-hydroxy. You want to measure the 25-hydroxy-D. That's in the middle of metabolism if you're a technical expert on vitamin D, but that has been validated as the correct measure, and for a long time tests weren't being properly done, and labs were reporting confusing information to doctors, and I agree with the Endocrine Society that the healthy vitamin D range is 50 to 80. And how much vitamin D should you take? As much as your body needs to get you into that 50 to 80 optimum range. And the reason I say that is Dr. Michael Hollick, a vitamin D expert who's also known as Dr. Sunshine, tells me that 40 million or more Americans do not absorb vitamin D from their gut because of digestive disturbances called enteropathy, which is atrophy of the surface of your digestive tract. And so they must take drops under the tongue, which is why I recommend drops under the tongue, 500 IU per drop, and the number of drops you need is the number that you as an individual need to get you into that 50 to 80 range.
Well, we talk a lot. I guess a program doesn't go by that we don't talk about vitamin D, and we recommend a D3 along with K2. Does that fit your approach, Dr.
Well,
Jaffe?
Definitely D3. If you're going to do it under the tongue, as I'm recommending it, so it is absorbed under the tongue before swallowing, then you want the D3 alone. And we put a little bit of rosemary oil as a natural preservative to protect the vitamin D. With regard to vitamins K, K1 and K2 are both helpful. Remember that vitamin K1 is converted by healthy metabolism into K2. And remember also that K1 has a 6 to 8 hour half-life, whereas vitamin K2 has a 3-day half-life, and it's actually fairly easy for vitamin D2 to build up. K2 to build up.
K2, right.
Yes.
Okay.
So
that's an important point. I wasn't aware of that.
It's a very important point. No. Vitamin D, as you know, is fat-soluble. However, D3 is the correct form, and 25-hydroxy-D is the correct test, and 50 to 80 nanograms per ml is the correct range. Now, excellent. With regard to vitamins K, we do recommend that you think about consuming both K1 and K2, but be careful because you can get plenty of K2 from leafy vegetables, sprouts, and seeds. When you take supplemental K2, I recommend that you take it kind of on an alternating day basis because it has such a long half-life and it has the potential to build up, whereas K1 doesn't.
That's a really great point. Did you get that, Dr. Jerry?
Yeah, absolutely. I'm sucking it in like a sponge here.
Yeah, I'm taking notes on that because that's really important.
Yes. Now, the next, if we can go on, the sixth is the omega-3 ratio, the ratio of omega-3 to omega-6 in your membranes. This was developed by Bill Harris. More than 8% is the goal. Most Americans take in many times more omega-6 than omega-3. I recommend that you supplement with EPA and DHA, the active forms of vitamin, the active EFA, the active good essential fatty acids, to balance out what probably is an excess of omega-6 in your diet. Now, you can reduce the omega-6 in your diet if you avoid chips, crisped foods, and edible oils. And in my home, where we have a permaculture biodynamic food forest in our front yard and a pretty whole foods-oriented kitchen, we cook with broth, we cook with wine, we cook with juice, we sometimes add water, but we never cook with edible oils and we never fry foods. So I agree with Mel Brooks, the 2,000-year-old man, stay away from fried foods.
Yeah, there is a story going out that you're going to be dancing at 120. I saw that someplace.
That's my plan, and you can hold me accountable for it. And not just there at 120, in a chair. I want to be up and dancing at 120. That's the goal. I think it's possible. I'm a little more than halfway there, as you know. So I'm functioning still as a 35 to 40-year-old, which, as far as I'm concerned, is pretty good because that's about half my age.
Well, your part is still brand new. That's the key.
Exactly.
Yes.
I will tell you that my dad is 101, and he just got. I just see him coming home now. He went to therapy because he wants to go to Europe this summer, and he wants to build up his stamina. And
good.
Typical Mediterranean diet our whole life.
Really? Excellent.
Yep.
Artemis Simopoulos, my colleague who really put omega-3 fatty acids on the map scientifically, and the Greek Mediterranean diet as well as the Mediterranean diet, she'll be thrilled to hear that.
Tell him, yeah, my dad is a testament to it. All right, so let's go on to another test, Dr. Jaffe.
Sure. Now, then there's a test, and this will be an unusual one. There's a test called 8-oxoguanine. And this is a test of oxidative damage in your nucleus DNA. So it's not a genetic test of your genes, but it's a test of whether your genes are being oxidized and damaged or not. And it's called 8-oxo, O-X-O-guanine, G-U-A-N-I-N-E, also known as 8-desoxyguanosine for those of you who are aficionados. And we really recommend that folks have that checked. It's a urine test. It's available from any large and full-function laboratory. But if you haven't heard of it, you're not alone, because it is one that is unusual.
Yeah, that's a new one for me. When I read your article, that was new to me. When I left practice, I'd never heard of that. So it's
I want you to know 8-oxoguanine. It's the DNA oxidative stress test, and the goal value, the best outcome value, is less than 5.3 nanograms per milligram creatinine. So it's a urine test. You can do it on a spot urine, so that makes it a little more convenient. You correct it to the amount of creatinine in the urine, and you want to have less than 5.3 nanograms per milligram of creatinine as an indication that your DNA is not being damaged.
Okay. So as oxidative damage to the DNA,
right.
That it's
when your DNA is being beaten up, you'll have more than 5.3 nanograms of the 8-oxoguanine per milligram creatinine. So that value will be above 5.3 if your DNA is being damaged, and then you want to bring in protective antioxidants and protective minerals to prevent that.
Okay. All right, let's go on to another test, Dr.
And
Jaffe.
the number 8 is one you do at home. We recommend you do this every day. And so after 6 or more hours of rest, the fluid in your bladder has equilibrated with the lining cells, and now you can measure the pH of the fluid, of the urine, to reflect the cellular metabolic acidosis risk. And healthy people will be between 6.5 and 7.5 on the pH scale. Basically, you tear off about 3 inches of a little colored strip of paper. You either pee directly on it, or you have a clean glass and you pee into the glass and you dip the strip and you look at the color. And you want to be green. If it's sand color, that's too acid. If it's darker blue, that's too alkaline. You want to be in the green middle zone. In almost all of these tests, it turns out it's a Goldilocks scenario. Not too much, not too little, just right is just right.
Okay, that's something. Dr. Jerry, you do that, do you not?
Yeah, well, I also, after I pee in the glass, I drink the rest, because in India, that's a urine therapy.
That's another subject for another time. Joanna Blood and others. I did that, actually, we'll talk about it another time, but I actually did that, and I understand the theory of it, which is very interesting if you're willing to pay attention to it. But the psychology is another whole point.
Yeah. I have an interesting question for you. A lot of patients or even people are talking about drinking this pH 9 water, and personally, I don't recommend it. I just want to get your take on it.
Well, my take, and I have been saying this consistently since Kangen and other companies delivered these machines, they are for laboratories where you want to determine the chemical pH of the water. They make the water alkaline by splitting water into an acid proton and a hydroxyl, what's called anion. The acid proton is drained off. The hydroxyl ions build up. You can get a pH of 9 or 10 or 11. But I'm telling you that hydroxyl ions are damaging to cells. And you have superoxide dismutase and catalase and various other enzymes in your body to prevent a hydroxyl radical from getting to your cells. Because if a hydroxyl radical, the way in which they make the water alkaline is chemical, not physiologic. If a hydroxyl radical got to your cell, it would damage it. Your body has many protective mechanisms to prevent such contact. So when the machine came out, and many people were buying them because they're not inexpensive and they, claim to alkalinize you, I went to the company and I said, "Do you have any science?" And they said, "Oh, yes, we have lots of science." And I said, "Could you send some to me?" And 6 months later, I had received nothing. So I went to them again, and I said, "Remember the science that you didn't get to send me? Could you send it now?" And the guy said, "Oh, yes, right away. And I got material in Japanese that said many people buy this machine, and they are very happy with it. And I'm confident that many people do buy it, and I wouldn't doubt that many of them are happy with it. But that is not science. Now, I had the National Library of Medicine translate to Japanese because I don't speak Japanese. And so I went back to them and I said, "Sorry, you sent me the marketing literature. You didn't send me the science, and I'm still waiting for the science because it doesn't exist."
Great point. Yeah,
what alkalinizes human beings and other animals are minerals like magnesium and potassium, but minerals, short-chain fatty acids. They alkalinize you. Long-chain fats acidify you. But short-chain fatty acids like medium-chain triglycerides will alkalinize you. Glutamine, an amino acid that can energize and repair your gut, alkalinizes you. But hydroxyl radicals, no. Keep the radicals out of your house and out of your body.
That's another great point, Dr. Jerry.
Oh, absolutely.
Well, Doctor, I told Justin I wouldn't keep you too long, but I do have to ask you one thing
Sure.
about Are you still recommending that when a blood test where you measure the LDL particles or the oxidized LDL ratio, HDL ratio?
Well, yes, you can do that. No, we continuously look at the world literature and evolve. So we did at one time recommend either measuring oxidized LDL or oxidized cholesterol directly. What we now recommend is the 8-oxoguanine. So you can measure oxidized cholesterol. You can measure oxidized cholesterol. You can measure oxidized LDL. They're very hard tests to get. There's only one company in America that offers the test. They happen to be in Brooklyn, New York. We got them to generalize the test, but they're very challenging to work with, picky. And so we actually have moved on, and you're welcome to measure that if you want, and I'm happy to talk with people about it, but the DNA oxidative stress test replaces it, as does the omega-3 index, as does the first morning urine pH and the HSCRP. So the 8 that I said are the 8 that we recommend, but you're welcome to do any additional tests that you want. Just remember that these essential and elective predictive biomarker tests have a goal value, and you want to know the goal value and see how people compare to that, and then put a lifestyle program together to get them back to their goal value if they're not at it.
Dr. Jaffe, I've learned a lot today. I think Dr. Jerry has also. And I think our listeners do. And I want to give them a chance to digest this. And maybe at some point in time, we could return and talk about the lifestyle modifications that can be made with different scenarios of the predictive results. Does that sound like something we could do?
Yes, Dr. Ron, Dr. Jerry, and any of your listeners, if you folks have questions that arise from this conversation, let Dr. Ron, let Dr. Jerry know. We'll put together a presentation, another conversation, but that's a bit more personal, that gets into an example. How come someone's thyroid and adrenals got rehabilitated when the magnesium, choline, and citrate were replenished, for example?
Well, I have a quick question
I think
for
that's really important.
You have a fantastic product called Pain Guard. I've been using it for many, many years. And basically it's quercetin. Does that have any science behind it to enhance mitochondrial function?
Well, I'm happy to send you a preprint of our chapter on polyphenolics that will be out in a few months. So yes, we're very much into the polyphenolics, but specifically quercetin dihydrate, which is different than all other quercetins, and specifically soluble OPC, that's different than all other of the flavanols. So yes, quercetin dihydrate plus soluble OPC are the safer, more effective ways of reducing HSCRP, because basically they help energize the granulocytes, the polymorphonuclear leukocytes, the wiggly dendritic cells that are responsible for touching every cell in your body every day and making sure that they're not abnormal, like the big C, and eliminating them if they're abnormal. That's called apoptosis. But also testing your connective tissue to make sure that the collagen, elastin, and infrastructure of your body is strong and renewed. So kind of important.
Well, thank you. Yeah.
Sure.
All right, Dr. Jaffe, again, thank you so much. I would like to talk to you about Broda Barnes at some time. He's really popular on our program.
He was a saint. Broda Barnes was a saint. Subclinical hypothyroidism and subclinical, then there's Myers, John Myers with his subclinical adrenalism. We could do a whole 45 minutes on that. That's a very common situation that is commonly overlooked and misunderstood or maybe even mistreated.
That would be great. I would really like to tackle that topic with you at some point, because we talk about it a lot. Dr. Jerry uses a lot of the Broda Barnes techniques, and so did I when I was in practice. In fact, I took his courses up in Connecticut. But be that as it may, I thank you so much. I don't want to take up any more of your time. You have been a fantastic guest with a wealth of knowledge for myself, Dr. Jerry, and our listeners. And as we develop this program and get questions from our listeners, I'll get back to you, and we'll set up another time if it's agreeable.
Please do. Please do. Justin's available at your pleasure.
All right. Thank you so much. Dr. Jerry, any
thank you.
parting? Just thank you so much, and God bless.
No,
and
Dr. Ron, Dr. Jerry, thank you very much. Look forward to another time.
We will have another conversation. Thank you. Dr. Jerry, I'm going to close this down now, and I'll get the MP3, and we'll play it again at 4, and we'll take some questions from our audience. Okay?
Yeah, perfect. You want to hang on for a second, or?
No, I'll call you.
Okay, call me. Okay.
All right, ladies and gentlemen, that is it. Interview with Dr. Russell Jaffe on Predictive Biomarkers. We'll see you at 4 p.m.
Support for this podcast comes from the University of Texas MD Anderson Cancer Center. With over 75 years of experience, their doctors treat more rare cancers in a single day than many physicians see in a lifetime. To become a patient, visit makingcancerhistory.com.